It's my pleasure to introduce Dr. Ken Offit, who's the Chief of the Clinical Genetics Services at Memorial. Thanks so much for coming. And Ken's going to talk to us about ethical and legal issues in multi-panel testing.
Thanks a lot. Mark and I sometimes give these tag teams, and he's done the ethics more recently, and it's fun for me to come back to this and talk to you about it. So we're going to talk about a bioethical framework, talk about the sort of model of bioethics, and then some ethical and legal implications to doing next-gen sequencing. The ethics, if you don't follow the rules, you may get slapped by your hospital ethics committee and not go to heaven. But if you don't follow the law, then you're going to pay a fine and go to jail. So we're going to talk about these two because they are sometimes the same, but not always. So the bioethical principles are principle-based, and we're going to frame it according to the principles of autonomy, do good, don't do harm, and justice. And that's sort of the common theme. And where these two come into conflict is paternalistic intervention, when you think something's better for somebody, but their autonomous rule might say, I don't think so. That's the ethical framework. This is the legal framework. The legal frameworks are statute-driven, so it's where you live, what country you're in, changes, and what state you're in. In New York, we have a law that says you can't do a genetic test on a sample without written informed consent, and it actually lists what the consent is. And if you don't follow the rules here, you can pay a serious fine and get into big trouble. And there are other rules that are of the road that apply in New York, and also there are federal rules as well that have to be taken into account. So we integrate all of this in our informed consent documents. The autonomy rule is what exactly are you testing me for? And we're going to talk in a minute about things that you might find out about that you didn't tell me necessarily you were interested in finding, or you said maybe you might find. Privacy, how private things are. We're going to talk about the duty to warn. We're going to talk about what the good that can come out of the test, but we're going to talk a lot about the harms of false reassurance, false alarm, harm to you guys in the audience, okay, which is the provider of the test as well. So a couple of years ago, Mark and I and a visiting fellow from Canada talked about what would be happening when we started doing next-gen sequencing, and we sort of speculated that it was going to be a challenge. And theoretically, we knew, and you're going to be hearing a lot in this talk, and there are posters outside about the notion of finding tumor-specific markers to treat for drugs. And here's a specific mutation. And in order to find out what mutations are inherited, which you're not interested in targeting, you run the normal at the same time, and you subtract out the normal, and you only target this, which is the abnormal. And a lot of the commercial companies won't even, or at least one foundation, won't even do the germline. But what we're interested in is the germline, because when you're looking and sequencing a tumor, you do use the normal as a comparison. And that normal means it's every gene that you've looked at in the tumor. So if you're looking at 450 genes, which we do here, that's going to include all of the genes that Mark mentioned, plus hundreds more. And so you're going to get all of that information once you start getting into this business. So we've recently had, and it's been announced and will be announced again, a $10 million starter package from a college classmate of mine who has an interest in biotech to get at that question, which is what are we going to do about the normal, the germline information in our tumor normal? Now, this 10 million sounds like a lot, but it's 100 million that the center has here for molecular oncology to do our tumor normal sequencing. And this stuff is not being paid for by insurance right now. So these types of philanthropic startups enable us to do the following. We'll take family histories on everybody that comes in, and we're going to find those genes that Dr. Robson pointed to, plus others. And for the folks that don't have genetic mutations, those will be sequenced to discover new things. So it's a gene discovery effort. It's off and running since the summer, and it raises certain ethical issues. One of the problems and challenges, as I mentioned, is you can sequence the tumor and then discover something in the germline. And this is a case we published before the NEHouse project, where we sequenced an ovarian tumor and found a very, very large deletion of PALB2 that we would not have found in the germline using conventional technology. So you can work backwards from tumors into germline for known genes, but also you can work backwards for things that are completely unknown. And in the early running of this, when whole exomes were being done or genomes were being done on average individuals, on average, you're going to find maybe 5, 10, 15 pathogenic mutations that each of you has that you're not aware of. Some of these will be trivial, but some of these could be life-threatening. They could cause you to have a heart arrhythmia or have an abnormal reaction to anesthesia. And although you're not intending necessarily to learn that information, coming into a cancer center, that information will come out. So this is the incidentalome. Are you at risk for Alzheimer's? Or you're going to get other diseases? Is your daddy? Okay. All of that stuff comes out, and it's quite a serious matter when you're coming back to somebody with information. So the President's task force tried to distinguish between the incidental information, which you find out, and a secondary finding, which is information that you're not necessarily seeking, but you expect you could learn. And you want individuals to be aware of that, and you want them to have the opportunity to opt in or opt out using the autonomy rule for getting information, inherited information, while they're coming in to get their tumor-specific information. So it's a vulnerable population. They want a cure for their disease. They want the targeted treatment. But do they want to know these secondary findings? So the Genetics Society said first, yeah, they absolutely should know. In fact, they have to know. And then they backed off a little bit and said, well, you could have a dialogue with folks to see if they want to know or not want to know these secondary findings. So this is the panel. It's actually 400 genes, and all of the genes that we've talked about for cancer predisposition are listed on these slides. And not only are the moderate penetrance genes that Mark talked about here, but a whole lot of other genes. So how do you do this and fulfill the New York State guidelines? So we said, well, cynically, we'll make a 3-minute video and we'll tell everybody about every possible gene that could ever exist and get their permission, which is basically what we did. And so this is 20 seconds of a 3-minute video with a very handsome person who you'll be hearing about later in this course, because he'll be giving you a talk. So it starts this way. We'll see if you actually get sound.
My name is David Hyman, and I'm the principal investigator of the
Turn it up a
Msk
little bit.
Impact Study. As part of your care at Memorial Sloan Kettering, your doctor has suggested that you have a test called Msk Impact. This video will help you understand what the Msk Impact Test is and whether you may also want to participate in some optional additional research we are doing.
Optional, it sounds like he's selling you insurance,
it's
right?
It's possible that we will find a mutation
And so
in the
halfway
DNA
through,
that
this
you
is
were
what
born
actually
with.
is said.
This would mean that you could have a genetic disease and be at increased risk for cancer or other diseases. These kinds of mutations may also increase the risk of a disease in a family member who shares this mutation. For example, we may see mutations in your BRCA1.
And there it goes, okay? So in 3 minutes, he's going to tell you about all the genes, but he's specifically talking about BRCA. So we set this up. It's called Consent C, and in all our tumor normals, you listen to Professor Hyman talk to you for 3 minutes about all of human genetics, and that we feel fulfills the New York State legal requirement for informed consent. And I say this glibly, but it's really quite serious because we do want to meet at least the intent of this. We do respect autonomy, and we do feel that individuals should have the opportunity. What's key about that is they're opting into this. So if they're not sure and they don't want to know this stuff, they're not into this. They're not going to get those results back. But if they opt in, they will. The Beneficence Rule we're not going to talk about. You know what that is. It's what you guys do. You're saving lives by doing these preventative surgeries in these BRCA carriers. You know all about MRI surveillance and tamoxifen. The paternalism is the duty to warn. The person may or may not want to know, but you feel you have to tell them. The case law for this started with a psychiatrist who didn't warn the girlfriend of a crazy young man at the University of California that she was at risk for getting killed, respecting his doctor-patient relationship. And he killed the girl, and the psychiatrist went to jail. There are some other legal cases, and the most famous one of these happened here at Memorial. This is Dr. Pack, and he was sued by the daughter of his patient for not having told her of an inherited risk for colon cancer that her father had that was passed to her that she should have told him. But he was dead when she sued him, so she sued his children for millions of dollars. And the case went forward in New Jersey, and I won't tell you the result, but the fact that even the lawsuit came to pass is terrifying because it means you can be sued or your kids can be sued for not warning a family member of a genetic condition of a patient you treated. Does HIPAA protect you? No. HIPAA says that you have to warn people of harm that could be passed on. I tried to stopgap this with the AMA and the ASCO in 2003 that said, forget the case law. All that applies for a physician is if you warn your patient, and it's their obligation to warn their family member. And I thought I was done with that, but I've been following this case law, and it's right after we did that, there was another state court, a claims court, that basically said no. There's a Malloy versus Meyer case that happened 2 years saying the physician's duty to the patient under traditional negligence law can be extended to the interest of the family. This was a Fragile X case. I'm going to do a whole medical legal grand rounds for surgery next month, and I have the details of these cases. And it's kind of, it's upsetting, right? Because the case law is still very strong for that you have an obligation to warn all the family members of your patients, which is, of course, impossible, right? So the duty to warn in the clinical scenario is there for a clinical incidental finding. It's ambiguous. This person has 2 Ivy League degrees in law and medicine. I still wouldn't want her defending me in a malpractice case because I don't think this is right, what she's saying. I think that this stuff is, there is a liability trail. But in the research realm, pure research, it's not clear that you need to tell folks about incidental findings. All right, now, the do no harm. This is stuff you'll be hearing. Dr. Kalfas in the audience and has championed this work, and I'm not going to give away the punchline here because this will be given, I'm sure, in the next talk. It's a major finding of a very low risk of a high-grade uterine cancer in BRCA1 mutation carriers. Well, once you make a discovery like this, there's also a liability because you have to communicate this and you have to now change your counseling because even if there's a low outcome, a low risk of a bad outcome, there's liability attached. And this comes in the non-maleficence as well as beneficence. Dr. Robson, Mark just showed you this slide of the flux that's going on with moderate penetrance genes. There's potential for harm if you're going to apply as de facto information data that has not yet been validated. And so there are risks involved. There are risks involved when you're taking all of these genetic new gene tests to patients because the variants, the missense mutations that you can't understand, and Mark didn't go into that because that's a whole other ball of wax, very high, okay, 15 to 60%, and these are uninterpretable results. And if you take somebody's ovaries out because of a missense mutation in any of these genes, which is not a deleterious mutation, that's doing harm potentially, and you can be sued for these things. What else can be done? Well, anything you could imagine could be done that's harmful. I love the one here about making synthetic DNA and planting it at the crime scene, okay? Yeah, I guess you could do that as well. But the major one that you all need to be aware of is the medical malpractice for not practicing state-of-the-art. This already happened for the breast ovarian. It was an early lawsuit that happened right after we wrote the New England Journal paper. And I've been following this. There was another one in 2012, Downs versus Trias in Connecticut. Plaintiff complained on defendant gynecologist's failure to advise her that she should have her ovaries removed because of a family history and not offering BRCA. The companies that are offering these tests that are not validated can also be sued. And this is the wife of the founder of Google, dressed very well, but also had to wear that dress to court because she was sued in a class action suit. And of course, she has deep pockets, and they'll overcome this. But it does raise the concern, even on the side of the testing company, that they're accountable. So finally is the justice and access, and I always add this on. By the way, it's nice to give the ethics talk at the beginning or at the end of the course, first time that's ever happened. You can do pre-implantation genetics for BRCA. We wrote about it and we've done it. But as you know, it's not always covered, and so we have a very bizarre type of sort of questionably ethical scenario here where we are enabling the wealthy to clean their gene pools up where those that can't afford it can. And that is a equity concern, right? A fairness concern, but we need to keep that into account as we're thinking on the larger level. The Myriad case, ding dong, the witch is dead, free. I love this one. I was down there for this case. That's actually me with Eric Lander, who actually won the case, although he didn't get credit. They just did what the Harvard professors told him to do. And they freed the genome. And what this did was this set off a torrent of next-generation sequencing by companies, some of whom aren't doing it so well. So there are liability to the company and liability to you guys. And this all directly came from the Myriad case, although I think I'm the only one who looks at it that way. Most view this as a great social and technological breakthrough, which it represented, but it also, with good things, come the risks. So there are profound social, ethical, and legal issues posed by genetic and genomic testing for adult onset disorders. Ethical solutions and legal remedies are not always the same, and so you can have a divergence. And the duty to warn is the most profound difference between ethical, professional normative standards and legal standards. And I can tell you stories about this in the question and answer period that'll terrify you. Next generation sequencing poses a challenge to current models and notions of duty to warn. Oncology is going to be the test case for these secondary findings as we're doing 450 gene panels. I've told you one approach that we've taken here for informed consent with genetic counselors essentially on the back end to give those results back. And then governmental support of this remains vitally important. And I'll end on that note. Thanks a lot.